equals most people picture the danger in surgery sitting in the hands of the surgeon. A slip of the scalpel, one wrong cut, human error under the bright lights. That's the image sold to us by every hospital drama ever filmed. But after 60, the real threat in an operating room isn't anywhere near the incision. It sits quietly in a mask over the face, in a clear liquid running into a vein, in a slow gas drifting through a tube. No drama, no cinematic moment, just a patient on a trajectory nobody warned them about. Often the first sign something has gone wrong shows up a week later. A grandmother who can't remember what day it is, or a grandfather who can't find the word for the cup in front of him. By then, the trajectory has already shifted, weeks at minimum, sometimes for a lifetime. What's actually happening is rarely explained before you sign the consent form. Let me change that. I'm Dr. Sam, a veteran anesthesiologist, 27 years behind the ether screen, one hand on the pulse, eyes on the monitor, a syringe ready on the tray. I've put thousands of older adults to sleep for surgery, and I've watched what happens to them in the days and weeks after. The part the family photos and the discharge summaries never quite capture. Today I'm going to show you the 5 things that actually cause the most harm to an older patient under anesthesia, because almost nobody walks you through them in advance. And you deserve that conversation. After 60, your body runs on a skeleton crew. The backup systems that used to stand by, a spare pair of kidneys with extra filtering capacity, a liver with extra metabolic room, a heart that could spike its rate on command, a brain with cognitive reserve to spare. They're still working, but the redundancies have been quietly retired. Only the main crew is left. And that main crew is doing fine under normal conditions. This is the part almost nobody gets right about aging. Your resting baseline looks almost identical to a 40-year-old's. Blood pressure, thinking, stamina. Those numbers are often still in range. Under stress is where the truth shows up. Anesthesia is stress. A gas that drops your blood pressure, a sedative that slows your breathing, a drug that takes hours longer to clear. Those are shifts a 40-year-old body absorbs without blinking. Yours at 70 no longer has the spare capacity. Every cushion it used to rely on has been drawn down. That is not an opinion. It is physiology. Hepatic blood flow drops roughly 10% per decade after 30. The amount of inhaled anesthetic you need to stay unconscious falls about 6% per decade after 40. Arteries have stiffened. The brain has less reserve when something goes wrong in the background. Here is why that matters the moment the anesthesia cart rolls up next to your gurney. Number 1. Dosing. The amount of anesthetic drug a 70-year-old body actually needs is substantially lower than what a 40-year-old needs, and a lot of older patients are still being anesthetized on numbers drawn up for younger bodies. Let me be honest with you, because this isn't anyone being careless. Dosing guidelines were built on average adult bodies decades ago, and training follows the guideline. Your anesthesiologist isn't being lazy. She's using the book she was taught from. The problem is that the book hasn't always kept up with what modern research has shown about how sensitive an older brain really is to these agents. What's happening in your body comes down to one number. The potency of an inhaled anesthetic is measured by minimum alveolar concentration, or MAC, the amount of gas in your lungs needed to keep the average patient unconscious through a surgical incision. MAC is not fixed. Starting at age 40, the MAC a body requires falls by roughly 6% for every decade of life. By 75, you need around 20% less gas than a young adult to reach the same depth of anesthesia. The aging brain has fewer acetylcholine receptors, fewer serotonin receptors, fewer dopamine receptors. The very receptors anesthetic agents act on. Each molecule lands on a smaller target and produces a bigger effect. If the dial on the vaporizer isn't turned down to match the age in front of it, you aren't sedated, you're overdosed. That 6% per decade decline isn't fringe. It's documented in standard anesthesiology reference texts used in every training program in the country, including the StatPearls Pharmacology series and peer-reviewed reviews of inhalational agents. In a 40-year-old, a small miscalculation in gas concentration gets absorbed and corrected within the hour. The liver breaks it down, kidneys push it out. The patient wakes up clean. After 60, with slower clearance and smaller margins, that same miscalculation stretches into deeper hypertension, oxygen drops you didn't need to have, and a recovery bay where you stay confused for hours longer than anyone planned. Small doesn't stay small in an older body. I've stood in a recovery bay watching a woman in her late 70s stare at the ceiling, unable to say her daughter's name, hours after a routine joint procedure that should have let her go home by dinner. That wasn't the surgery. It was the dose. The fix costs nothing. At your pre-operative visit, ask directly, will my anesthetic dosing be adjusted for my age, not only for my weight? Write those exact words down. A good anesthesiologist will welcome the question and walk you through how she calculates it. Number 2, your liver. Specifically, how long it takes your liver to clear what the anesthesiologist just put into you, and what happens while it tries. Most people never connect the liver to surgery. An operation feels like a heart event, a lung event, a nerve event. It is all of those. But it's also, quietly, a liver event, because the liver has to disassemble and eliminate every anesthetic drug, every sedative, every opioid, every muscle relaxant you receive during the procedure. Here's what's happening behind the scenes. By the time you reach 70, your liver has lost roughly 35% of its mass compared to the liver of a young adult. Hepatic blood flow has dropped about 10% per decade since age 30. The family of enzymes responsible for breaking down most anesthetic drugs, the cytochrome P450 system, particularly an isoenzyme called CYP2E1, has slowed and become less efficient. None of this produces symptoms on a normal Tuesday. You don't feel your liver. Nobody notices it operating at 70% capacity. But the moment a dose of anesthetic hits that system, the consequences compound. Drugs that should clear in an hour sit in your bloodstream for 2, 3, 5 hours. Their byproducts, some neuroactive in their own right, keep circulating. Your brain is soaking in anesthetic long after the surgical drape has come off. Reviews in the literature on anesthetic considerations in the geriatric population, along with standard geriatric pharmacology texts, document this prolonged exposure pattern consistently. It's one of the most under-discussed realities in adult surgery. In a 40-year-old, the liver has full mass, full blood flow, and full enzymatic horsepower. Anesthetic agents come in and come out on a predictable schedule. After 60, with a smaller, slower, less flowing liver, the same procedure leaves you steeping in sedatives much longer than the chart says. Recovery stretches, delirium risk climbs, the margin shrinks. I've watched patients come out of the operating room looking stable on every monitor. Blood pressure, oxygen, heart rate, and 3 hours later, still unable to tell me what year it is, because the drug hasn't left their system, and nobody on the recovery team will know that until it finally does. When was the last time any doctor asked you about your liver function before booking a surgery? The fix is two-part. Ask your anesthesiologist about your pre-operative liver function. A basic blood panel will tell you, and ask whether a technique called total intravenous anesthesia, or TIVA, would be appropriate for your procedure, since some intravenous agents clear more predictably in older patients than inhaled gases do. Before we go to the next one, a question for you. Have you ever actually met your anesthesiologist before the morning of a surgery? Drop yes or no in the comments below. I read them. Number 3. The volatile gases themselves and what they do to the protective wall around your brain. This is the item almost nobody discusses, and the one that changed how I think about every older patient on my schedule. The inhaled anesthetics still used in most operating rooms, isoflurane, sevoflurane, desflurane, are highly fat-soluble molecules. That solubility is exactly why they work. They cross biological membranes easily, slip into the brain within seconds, and switch off consciousness. The same property is what makes them dangerous for an older brain. Your brain is protected by something called the blood-brain barrier, a tight wall of specialized cells that decides what gets into brain tissue and what doesn't. This barrier is what keeps inflammatory chemicals circulating in your bloodstream during an infection, a surgery, or a stress response from flooding directly into your neurons. Clinical and laboratory studies published over the last 2 decades have shown repeatedly that volatile anesthetics at standard clinical concentrations actively compromise it. They weaken the tight junctions between the cells that form the wall. The barrier opens up. In a younger body, it reseals quickly once the gas is gone. But in an older brain, that repair is delayed, sometimes by days. During that window, and your body is also flooded with surgical inflammatory signals. The tissue trauma of the procedure releases cytokines, tumor necrosis factor alpha, interleukin-1 beta, interleukin-6 into your bloodstream. In a young patient with an intact barrier, those cytokines stay out of the brain. But in an older patient under a volatile anesthetic, the barrier is leaky, and the cytokines pour in. Once inside, they activate the brain's resident immune cells, called microglia, which start producing their own inflammatory signals in a self-amplifying loop. Cholinergic neurons that would normally calm the microglia are already depleted in an older brain, so the fire burns longer. Research published in the British Journal of Anesthesia and in specialized reviews in Frontiers in Cellular Neuroscience has documented this cascade in detail. This isn't theoretical. The mechanism has been measured in aged animal models and increasingly in human patients. In a 40-year-old with a strong cholinergic reserve, neuroinflammation of this kind flares and resolves. After 60, with reduced cholinergic capacity and slower barrier repair, it can smolder for weeks. That smoldering is a major reason some patients come out of surgery not quite themselves and stay that way for longer than anyone expected. The fix is a conversation with the anesthesiologist before the day of surgery. Ask if your procedure can be done with regional anesthesia, a spinal block, an epidural, a peripheral nerve block, rather than general anesthesia with inhaled gas. For a wide range of orthopedic, urologic, and lower abdominal surgeries, the answer is yes, and the evidence favors it in older adults where it's feasible. Number 4. blood pressure on the operating table, and the silent damage nobody mentions when you wake up. This one pairs tightly with the last one, and it's the reason they have to be understood together. Volatile anesthetics aren't just central nervous system depressants. They're also powerful vasodilators and direct myocardial depressants, meaning they relax the walls of your blood vessels and weaken the squeeze of your heart at the same time. In a younger body, the heart compensates. It speeds up. A reflex called tachycardic rescue kicks in and keeps the pressure up. The older heart can't do that the same way. Conduction slows, ventricles stiffen, compensatory reflexes blunt. What this looks like in practice is a drop in mean arterial pressure during induction that might last only a few minutes on the screen, but is transmitting damage to every organ downstream. Your brain runs on perfusion. The kidneys run on perfusion. Cardiac tissue itself runs on perfusion. When perfusion drops, tissue is starved. Data summarized in reviews of pre-anesthetic blood pressure deviations has shown that mean pre-anesthetic systolic readings falling below 119/63 in older patients significantly amplifies 30-day postoperative mortality risk. In a 40-year-old, a brief dip is shrugged off. After 60, with cerebral vessels already partially narrowed by atherosclerosis and a kidney already filtering at reduced capacity, the same dip can produce microstrokes too small to see on imaging, but big enough to measure on a neuropsychological test 3 months later. It can produce acute kidney injury that shows up in your creatinine a day after you go home. Damage is real. It just doesn't announce itself in the recovery bay. The fix is a direct question at the pre-op visit. Ask your anesthesiologist, what is your specific plan for maintaining my blood pressure during induction and through the case, and what reading will you treat as the floor for my age? A thoughtful answer will include a specific number and a specific backup drug. Number 5. Postoperative cognitive dysfunction, the quiet aftermath. This is the one that pays off everything we just covered, and it's the one almost no hospital consent form tells you about. The medical community has given it several names over the years. Postoperative delirium for the acute form in the first days, POCD, or postoperative cognitive dysfunction for the weeks and months that follow. The newer umbrella term is perioperative neurocognitive disorders. Names change. The reality doesn't. Here's what the data actually shows. The original ISPOCD-1 trial, the first large multinational study of this phenomenon, followed 1,218 patients age 60 and older who had major non-cardiac surgery. They found cognitive dysfunction in about 26% of patients at 1 week after surgery, and about 10% still showing measurable decline at 3 months. A review article in the British Journal of Anesthesia estimated that roughly 12% of previously cognitively well older adults develop clinically significant cognitive dysfunction after anesthesia and surgery. Recent prospective work using modern digital cognitive assessments has documented rates above 40% at both the 1 week and 3 month marks. For postoperative delirium, the acute confused state, rates reach 40% of patients over 60 after major surgery. These aren't rare events. They are not complications reserved for frail patients. Cognitively healthy older adults walk into the hospital sharp and go home with a gap they can feel. One more finding has stayed with me for years. In a study of older adults undergoing vascular surgery, 68% of patients were found to meet the criteria for pre-existing mild cognitive impairment on formal testing, and in 88% of those cases, the impairment had been completely undetected before the surgery. They looked normal at home. Intake questions got answered. Nobody ran a cognitive baseline. Then the anesthetic exposure stripped away the compensations they'd been quietly relying on for years. In a 40-year-old, a full-capacity brain absorbs the inflammation and recovers. After 60, a brain with no baseline on record and no one watching for delirium is a brain that can slip by a grade and no one will notice until the family does. Months later, at Thanksgiving, when Grandma can't remember the name of the dog, the fix is the most important thing I'm going to say in this whole video. Before you consent to surgery under general anesthesia, ask for a pre-operative cognitive baseline test. A Montreal cognitive assessment or a mini-cog will do. 10 minutes in a chair, free. Available at most pre-op clinics if you request it. That score becomes the anchor that lets your medical team detect meaningful decline afterward, trigger prevention protocols, and adjust your plan if the risk is too high. Let me step back for a moment because I don't want you to leave with a list of 5 separate problems. These 5 items aren't 5 problems. They are one problem wearing 5 faces. A dose too high for an older brain pushes a liver that can't clear it fast enough, which keeps the brain soaking in drug that weakens the blood-brain barrier, which lets surgical inflammation into brain tissue where an older immune response can't switch off, while blood pressure drops starve that same tissue of oxygen. The unifying engine underneath all of it is neuroinflammation. A single biological fire, each of these factors either lights or fuels. That's what shows up on the other side as delirium in the recovery bay and cognitive dysfunction at the follow-up. Not 5 separate accidents, one inflammatory cascade with 5 easy entry points. Protecting an older brain in surgery isn't about solving 5 problems. It's about not lighting the fire. Here's what I want you to do, whether you have a surgery scheduled next month or none planned at all. Tonight, write 3 questions on a single sheet of paper. Question 1. Will my anesthetic dose be adjusted for my age, not only my weight? Question 2. What is your specific plan for preventing post-operative delirium in my case? And will you perform a cognitive baseline test before my procedure? Question 3. Can this operation be done under regional or neuraxial anesthesia, a spinal block, epidural, or nerve block, instead of general anesthesia with inhaled gas? Put those 3 questions in the pocket of the jacket you wear to medical appointments. If you have a surgery on the calendar, call the surgeon's office tomorrow and ask for a pre-anesthesia consultation before the day of the procedure, not the morning of, before. Most hospitals will accommodate that request for a non-emergency surgery. At the appointment, ask your 3 questions and bring a family member or friend with you. A second set of ears after 60 is not optional. It's standard practice. Let me tell you something I don't usually put into a video. There's a patient I still think about, years later. A retired school teacher, 73, sharp as anyone you'd meet. She came in for an elective procedure that had nothing to do with her brain. She'd done the research, printed out questions, asked the surgeon about bleeding risk and infection. She never asked about anesthesia because she had no idea she was supposed to. We did our work as it had been done for years. By the next day, her daughter was telling me her mother kept asking what time lunch was 3 times in an hour. 6 months later, she still wasn't back to herself. The family had the conversation no one expects to have about selling the house, about whether she could still live alone. She recovered, partially, but something had shifted that didn't shift back. The part that haunts me isn't that she came out of surgery cognitively different. It's that nobody told her, before she signed the form, that this was a possibility she could have prepared for. She could have asked for a baseline, for a regional technique, for the conversation itself. That she didn't know to ask is on us. Now you do. Let me bring this together, because I don't want you leaving here with information you've forgotten by dinner. 5 things. 1. Confirm your anesthetic dose is being adjusted for your age, not only your weight. 2. Get a basic liver function panel before elective surgery and ask about intravenous anesthetic options. 3. Ask whether regional anesthesia, a spinal block, epidural, or nerve block, can replace general anesthesia with inhaled gases for your procedure. 4. Have your anesthesiologist name a specific floor for your intraoperative blood pressure and tell you how she'll defend it. 5. Request a pre-operative cognitive baseline test and ask that a delirium prevention protocol be put in place for your recovery. None of these requests are unusual. Not one costs you anything. Everyone shifts the odds in your favor in a way no surgical technique ever will. Which of these 5 surprised you the most? Tell me in the comments below and tag the item number so I can group them. If this helped you see something you hadn't seen before, send it to the person in your life who has a surgery scheduled. A brother, a sister, an in-law, the neighbor who just found out she needs a knee replacement next month. She doesn't know to ask for a pre-anesthesia consult. Now she will. Then subscribe if you want to stay ahead of the conversations modern medicine doesn't always make time for, because next week I'm going to break down something seniors are told is routine, that after 75 changes the math in ways most families never hear about. Walk into every medical conversation from here on as the expert on your own history, because no one else in that room has lived it the way you have. One last thing. Everything I've shared here is general information based on current research and my clinical experience as Dr. Sam. It isn't personal medical advice tailored to your history, your medications, your prior surgeries, your baseline. Those are yours. Before changing any plan, talk to your own physician, pharmacist, or anesthesiologist. They know you. I don't. That difference matters more than anything a video can cover. Be well and be your own advocate in every room you walk into.